welcome and thank you all for joining this webinar. It's currently 5 p.m. here in Los Angeles. Good evening, good day, and good morning wherever you are in the world. Last count, I think we had about 360 registrants and many more joining as we speak. So today we got a really interesting webinar for you guys on the lateral approach. Many are familiar with it. And more importantly, we thought we'd discuss more about what not to do. Pitfalls, problems with it, and maybe when not to go lateral. So we have an amazing faculty, and I'm going to have each one of them introduce themselves. So I'm going to go first with Chol Kim. Go for it.
Hello there, I'm Chol Kim. I'm in San Diego. I think my background is at overlooking Torrey Pines and Scripps, La Jolla Shores Beach. But I'm definitely not there, so don't worry. I'm pulled up in my office in a dark, dank place and hanging in there with everybody. So thank you very much for having me so that I can enjoy hanging out with you guys because virtual is still better than nothing.
Cristiano.
Hi, Neil. Hi, friends. I'm Cristiano Menezes from Belo Horizonte, Brazil. And I'm so glad to participate of this lateral approach webinar. We are now with 10-year experience, and I think that will be great to participate. Thank you.
Ron?
Yeah, thanks, Neil. My name's Ron Lehman. I'm from Columbia University and the Spine Hospital in New York City, and certainly been very interested about the lateral approach and anti-psoas approach now for 5 or 6 years. I think this is a great way to look at it. I think gives us a nice 360 view of when to do it, when not to do it. So thank you to the rest of the faculty and for the Seattle Science Foundation for having me.
Rod? Is Rod in the lab? Can he introduce himself? I'll introduce him. I think what's amazing about this particular webinar is we're actually going to have live surgery from the world famous Swedish science lab. And they're actually going to do a cadaver dissection as well as ALL resection. They can get to a carpectomy and we can discuss techniques at that time. Rod Asukian is going to do that with Dr. Jimenez, and they both will be working in the lab and will come live to you. So the format as it stands is Dr. Chol Kim is going to lead the way talking about different techniques and more actually talking about maybe when not to do lateral. Maybe there are better techniques we have. It's not a be-all, end-all for every single procedure in spine, and that's going to be sort of the focus. This will be followed by Cristiano talking about the trans-psoas lateral approach, probably the most common one. Again, sort of focusing on the problems, technical pitfalls, when not to do it maybe. And then we have the lab. We have a 20-minute lab cadaver dissection where we can delve into the techniques. And then Ron Lehman's going to talk about the pre-psoas approach. Again, similarly, when do we do it? And maybe more importantly, I keep saying when not to do it. And when are the issues that we need to deal with? And eventually I'll end with how we use lateral in our protocol for circumferential, minimally invasive correction of severe adult spinal deformity. So we have 5 minutes of discussion after each speaker. We also have another 10 minutes at the end if you have time. More importantly is the chat box. Please use it. We'll try to get to it as much as we can and get you guys answered. So without much ado, let's get Dr. Kim going. Joe?
All righty, thank you very much, Neil, and to Seattle Science Foundation for having me. Can you give me a remote control over the mouse? Thank you. I already had the remote controller, it's just slow. Let me start out with a case presentation of a 78-year-old gentleman. He's retired. He's got worsening pain with radiculopathy. But the thing that's bothering him the most is that he walks for exercise. You know, like I hate walking. I like punching things and racing down a mountain. My wife likes walking, but she loves walking. So people that love walking, you take that away from them and they get very miserable. His ODI is 38. His back pain score is 8 out of 10. And his leg pain score is 0 and 8. So he does have some ongoing radiculopathy as well as neurogenic claudication. And he's pretty healthy overall. And here are his x-rays. These are upright AP and lateral. The flexion extension views, it's not moving much, but I think you can see a spondy at 3, 4, and 4, 5. And here's the MRI. This is 3, 4. This level is 4-5. And I think you can see at 3-4, there's moderate to severe stenosis, and 4-5, there's severe stenosis. So when you get to this point where the patient's failed non-operative treatment and we're starting to think about what type of surgery that we're going to do, this is kind of like how I go about deciding where to go: anterior, posterior, sideways, backwards, forwards, etc. So I think everyone thinks like this. The first question probably is, does a person need a fusion? Because they certainly need a decompression. And let's just say, for the sake of argument, that we just have decided that doing a fusion on this patient is desirable. He's got a 2-level spondy. He's got a lot of back pain. He doesn't have a lot of motion or facet fluid signs, but a lot of patients like this with a spondy, they don't seem to do as well if you do a good minimal invasive reconstruction than a good minimal invasive or even open decompression over the long term. So for the sake of argument, let's decide that a fusion is desirable in that patient. And when you get to that point, my next question is it worthwhile doing an inner body? And for me, I almost always use an inner body for a variety of reasons. Better fusion environment, better control of the inner body shape to allow for deformity correction, etc. And the fusion rate is higher than a posterolateral fusion overall. So those are all positives, but there are often times where you don't want to use an inner body for one reason or another. But let's say, for the sake of argument, that here's a patient that has failed non-operative treatment. They can't stay like this. We decided we needed a fusion and we want to do an inner body. And when you get to that point, the next kind of decision tree is whether or not to go anterior, posterior. And going posterior, it's not that, you don't have to think that much. But when you decide, should I go anterior, a lot of thought has to come into place. And my brain is thinking, should I do an A-lift, a lateral, or a slightly oblique lateral, called an O-lift or an ATP, however you want to say it, where you go anterior to the psoas. So how do I go about looking at things like that? So again, the first question is anterior, posterior. If you can go anterior, it is nice to go anterior for a variety of reasons. And I think everyone that's here agrees with it, because going anterior allows you to put in a much bigger cage. You can control the anterior annulus and anterior longitudinal ligament better and decide if you want to resect it or not. And you get a lot more control over the inner body space. So I usually ask myself, why should I not go anterior? So this patient is a 3-4-4-5. And when I'm thinking anterior, I immediately rule out A-lifts. Now, that may or may not be fair, but at least in my hands and in the literature, if I had a 5-1 problem, I would love to do an A-lift, because a 5-1 A-lift is a great operation, very low complication rate, very quick surgery. And if you look at the literature, the complication rate between L5S1 and L4-5 and above, it's probably 3 orders of magnitude higher in terms of complications. So if it was 5-1, it would be easy. But it's 3-4 and 4-5, so I'm leaning toward doing something lateral. And if I'm leaning toward doing something lateral, my next step is really to ask a variety of questions related to access. And these are exercises that we never did before until the lateral procedure came up. So it's really important that you don't just go barreling in there with surgery when you're when you're thinking about doing a lateral procedure. You do posterior and A-lift, probably not as big of a deal, but a lateral, you got to really look. So the first thing I do is I try to find a coronal scout image like this, and I draw a line along the upper end plate of L5. And I ask myself, will that line clear the iliac crest? And if it doesn't completely clear the iliac crest, I immediately know I'm going to have a challenge, because imagine you put a retractor in there and you start opening up that retractor. Unless you can get that disc space up and over that crest of the iliac crest, the retractor will start to angulate cephalad, and now you're going to be in a surgical trajectory where you're going into the vertebral body of 5. So, the experienced surgeons use angled instruments when necessary, but that makes the surgery like an order of magnitude more difficult. So I'm already thinking, I do not want to do a direct transpsoas true lateral on this patient if I have another choice. So that's the first thing that tells me direct lateral probably won't be great, but oblique lateral will be all right. But that's not where it ends, unfortunately, because you also have to ask yourself, what's going on with what I call the safe zone? Because when you're going down in the lateral trajectory, whether you do a anterior to the psoas, O-lift approach, or a direct lateral, if you want to get the cage where I typically want the cage, you have to look at the safe zone. So this is where I typically would like the cage, sometimes even slightly more anterior. And to put a cage like that, you have to take the cob and go out the other side. And look what would happen if you did that. The common iliac vessel's right there. And this is one of those situations where the lateral surgery is kind of boring and really, really easy, unless you get into trouble, and then it could be lethal. So it's like mostly boredom with an occasional panic, because terrible things can happen. So if you don't recognize this, you take a cob down and you barrel through this, you can lacerate that blood vessel, and you're standing on the contralateral side. You can imagine what a problem that could be. So I'm immediately thinking, do I really want to go lateral, put a cage here with this there? Probably not. Neil could probably do it, but now besides that, you also have to look at nerves. So if you look at where the nerves are, it's usually easy to find, especially on a T1 weighted axial. So we don't look at T1 weighted axials very often. You can see this on a T2, but the T1 axial is really sharp. It's, you know, low TE, low elongation times and relaxation times. So it's like a camera. Everything's sharper and the fat is bright. So all nerves are surrounded by a bundle of fat, and you can see one of the nerve root bundles right here. So that's fine, but look around a little bit more carefully. There's something up here. That's probably one of the nerve roots. So there's yet another reason why going lateral for me, even before I even consider surgery, just looking at the preoperative images tells me it's not a good idea. So you know, this Mickey Mouse ear sign that you see, it's actually not the Mickey Mouse ears itself. It's a secondary sign of a, low riding L4 pelvis, low riding L4-5 disc level deep in the pelvis, which means that the bifurcation will occur earlier and the iliac crest will be higher. And anything like that at 4-5, you just do not want to even think about doing a lateral unless everything else is not easy and you're particularly skilled at doing that surgery. So the take-home message, so if you look at a bunch of studies, we looked at about 100 MRIs in spine patients. So they had like DDD, spondy, degen scoli, pathology that we would see in the spine practice, not just the general population or a bunch of cadavers. And we looked at that safe zone. So you look at every MRI, every level, and you identify the nerve root bundle and you identify where the blood vessels are, and you ask yourself what the limits of this space is. I call it the safe zone. And turns out, and I think we all know this, at L1-2 and above, L3-4 and above, that safe zone is relatively big. But at 4-5, it just goes quick, very narrow. So 4-5 is always the one that dictates a lot of what I decide in terms of strategy. And it's always the most challenging for not only the safe zone, but the iliac crest being in the way. Now, having said all that, before you decide on an A-lift, what I do is when I decide I'm going to operate on somebody and I'm thinking about an L-lift, I run back into my office and look through all the imaging studies, because it doesn't matter what the papers show. You want to know exactly where this particular patient's neurovascular structures are and where the safe zone is for each level that you're operating on. So you check every one, every patient, every level. So it's tedious, but that's what it's required to be a good lateral surgeon. You have to be a little bit more thoughtful and spend a little bit more time. So what did I do with this particular surgery? I didn't go lateral. I don't like going anterior that much. So I did an endo T-lift or an MIS T-lift, but with an endoscopically assisted percutaneous interbody reconstruction. One of my favorite surgeries now. This patient was a little osteoporotic, so we did some cement augmentation. She went on post-op day 1. Her ODI went from 38 to 6. And then, I get a bunch of stuff, but one of the things that I get is a PGII. It's a validated outcome measure called the Patient Global Impression of Improvement. It's basically asking the patient, are you very much better, a little better? And I ask that for all my patients. And, this is a patient that, in the words of Californians, they are stoked. So that's kind of how I go about taking care of patients and trying to go back and forth between being an anterior surgeon and a posterior surgeon, and having a full toolbox of of equipment that allows you to tackle every patient with the precise, most optimum strategy that you have, and that'll vary from patient to patient. So thank you for having me.
They're going to come up. You're almost at the ball rolling. Actually, I do have a question from from the chat room, from Jens Chapman, really, and it's a pretty direct question. That particular patient, though, could you kind of walk us through why you decided to do a fusion as opposed to maybe just a decompression?
Yeah, probably because they had a lot of back pain, and but I agree with you. It's one of those things where I'm trying going back and forth between a fusion and just a simple decompression. So I don't fuse every spondy, but I've noticed that at least in my hands, even my minimally invasive decompressions, they are not as durable as a good MIS fusion. So if a patient has back pain, they have a spondy, and they're relatively healthy, and I can do a surgery that is relatively minimally invasive, and it's a 50-50 call, I'll tend to make a mistake of commission and omission. But I totally agree with you. We could have probably done a decompression without fusion.
Just to ask your experience, right? If you were to look at all the fusions you do today, could you sort of just give a rough estimate how many laterals you do? I know it varies from patient to patient. In general,
how many decompressions?
So lateral fusions, as opposed to a PLIF or a TLIF or an ALIF. How many lateral fusions are you doing?
Well, for 1 and 2 level surgeries, I tend to do everything posterior because of the whole logistics of going front back, and the repositioning is just much more efficient and less cumbersome. Unless they need a really aggressive inner body realignment. I love doing laterals when there's like a multi-level reconstruction with deformity, like degen scoli. I used to do a lot of those. And when I did a lot of deformity, I would do probably 50-50 laterals and 50-50 posterior inner body. And I don't do PLIFs. I do almost all MIS T-lifts if I go posterior. But now I would say that it's more like 80-20, mainly because I'm focusing on 1 and 2 level surgeries, trying to do them quickly and in a manner where they can go home either the same day or the very next morning. And because I find the anterior posterior, even a really good lateral, to be slightly more difficult than to recover from in my hands than a good MIS T-lift. And certainly now that I'm doing more endo T-lifts, for 1 and 2 levels, there's a distinct difference between the endo T-lift and the lateral. But I mean, you need to go lateral or anterior when you have a really bad disc space. So it's just the idiosyncrasy of my practice currently that I don't do as many laterals as I used to.
There's one more question. I think you kind of addressed this on the Mickey Mouse ears, right? This is from Hyunbei, who basically said, could you comment on the morphology of the muscle? And I guess how much importance do you give Mickey Mouse ears?
Yep, I'm really glad Hyunbei brought that up. Because everything Hyunbei says is really smart, and I love the man. But it's important because it's not the morphology of the muscle that I think is a big deal, but the fact that a person that has Mickey Mouse ears at the level that you're about to operate on is likely somebody that has almost like a transitional spine where the 4-5 disc level or whatever disc level has the Mickey Mouse ears is really deep in the pelvis. And by that point, the vessels have bifurcated. The iliac crest is really high, making it difficult to access physically the disc space. And it just turns out that as you go further down on the lumbar spine, the nerve root bundle gets bigger and more anterior. So if you just compare like the L2-3 level with the L4-5 level, you'll notice the nerve root bundle's really posterior at L2-3 and really safe, whereas at 4-5 it starts to migrate up. So it just simply means that it's a 4-5 level that's lower down anatomically in the pelvis. And so everything is shifted toward a more caudal morphology, including anteriorized blood vessels, bifurcated, anteriorized nerve bundles, early bifurcated blood vessels, and a high iliac crest. So don't just look at the psoas muscle, look at the iliac crest, the nerves, and the blood vessels, as well as the muscle.
Thank you, Chol. That was great. For want of time, I know we need to move on. But keep the questions coming, guys, in your chat box. Our next talk's by Cristiano Menezes from Brazil, who's going to talk to us specifically about transpsoas laterals and the issues with it. Go, Cristiano.
Okay, Neil, good evening again, Neil and friends, and welcome all the participants. Let's talk about when transpsoas is inappropriate. These are our goals for today's webinar. Determine a safe corridor for transpsoas approach, recognize the elements involved in risk for this specific approach, and apply strategies to avoid complications. Revising the lateral anatomy, what we need for this approach is to create a safe corridor from the skin to the psoas muscle, right? Passing through the abdominal wall layers, the heteroperitoneal space, the psoas itself, until reach the lateral annulus. The psoas houses the lumbar plexus, which may be under risk during this passage. Any variation in this scenario must be understood by the surgeon to mitigate major risk of any injury. Next one again. Next one, please. There is no doubt that extreme lateral interbody fusion is a game changer. One slide before, please. Thank you. One before, Alexis. Sorry about that, but I have some problems with my slides changing here. There's no doubt that extreme lateral interbody fusion is a game changer in the history of spine surgery. It is powerful due to anterior column manipulation, implantation of a large graft, at the same time that preserves soft tissues, being minimally disrupted. Next one. Next slide, please. And to note, there's more than 500 peer-reviewed articles attesting its safety. The key, in my point of view, is the concept of proceduralization, which means competencies required to adopt the technique, its reproducibility, and a unique integration of technology, the type of retractor we use, and neuromonitoring coupled. But obviously, these aspects do not put away the need of patient selection, which is a totally surgeon-driven attitude. And as the basis of the medical knowledge, all procedures have, one slide back, please. All the procedures have its signature. All the procedures have specific indications, and no technique is appropriate for everybody. Next one. Next one, please. Gotcha. Then our initial question, when is the transpsoas approach inappropriate? Here we have three main possible contraindications based on transitional anatomy, previous heteroperitoneal surgery, and some specific medical conditions, in technically demanding situations. So let's get started with transitional anatomy. Next one. Okay, we all know that the typical lumbar segment, we have the psoas well adherent to lateral disc, the vessels in an anterior position, and the plexus in the posterior quarter of the disc space. So the safe zone is described by Regev, as shown by Chal in the last presentation, is quite large. The Regev paper shows a large in a normal anatomic picture. But in some transitional segments, the anatomy changes with the psoas away from the lateral disc annulus. The vessels taking a more lateral position due to a high bifurcation, and the plexus more anterior position. So the safe zone is definitely narrowed. As in this patient, this is a young lady that came to visit me a month ago, and she was with indication for lateral surgery, but she has a teardrop psoas. She has lateral position of the right iliac vein in a risky position, and the anteriorization of the lumbar plexus. So this patient, she's not candidate for any lateral approach surgery at all. Next slide, please. So despite the methodological differences between papers, there's a broad consistency showing that the majority of the lateral disc space is free of nerves at all levels, including 4-5. But in transitional anatomy, which incidence of 6 mobile segments in lumbar spine is around 2 to 5%, some soft tissues variations may occur as a more anterior position of the lumbar plexus. In this study, pass the next slide, please. Next slide. So this is a transitional segment we're describing during my PhD paper published in 2015, showing that this type of situation occurs not very often. And in this paper of Smith in 2012, 2.8 of 351 patients exhibited this type of anatomical variation. Next one, please. Excellent. So moving forward, we have previous retroperitoneal surgery or medical conditions as possible contraindications. Here we have, just to note, we don't consider a revision in the same level or in the same side as a contraindication to reaccess after a transpsoas approach. But we have here more rare conditions, medical conditions, and some previous approaches. So as like nephrectomies, as these pictures here, giant renal cysts, tumors, megacolon, or even renal transplant with pelvic kidney. Next one, please. Yeah, next one. Got it. Finally, some technically demanding situation can increase the risk in transpsoas approach in less experienced hands. Next one. High crest, as Shaw mentioned, just to warn, just a warning message. We do not use jackknife brake in any case to take away the high crest because it puts the psoas and plex under tension, and this is dangerous. So we do use like this angle instruments. So this type of instruments, you can deliver the cage, prepare this space, but it can be challenged and potentially increase the risk associated with the approach. Once you change the natural, straightforward steps that characterizes the transpsoas technique. Next one, please. Next slide, please. Besides, for complex cases, one must plan the approach based on anatomical challenges as vertebral rotation, large osteophytes, collapsed disc spaces, fragile end plates, dual osteoporosis to mitigate complications. So as take-home messages, lateral transpsoas is a powerful MIS tool with low complication rates, but each technique must respect its signature. It is inappropriate in transitional anatomy, in previous retroperitoneal surgery or some medical conditions, in technically demanding situations, especially for less experienced surgeons' hands. Thank you.
Algorithm as to how you deal with the lumbar plexus intraoperatively. Let's say the signals go on, you see a nerve there. What do you do? What do you talk us through that, and how do you sort of avoid that or minimize any problems?
Yeah, Neil, I think that this is a great question. We are now with more than 600 cases done in a 10-year experience, and trust me, I rarely had any motor problems in my cases. And I think that the key point is to get the right spot to put your dilator, to check with your neuromonitoring, and more than this, to be effective as the retraction, the psoas retraction time. So in average, we are now publishing a paper, prospective paper, comparing graft, two different types of graft. And there are various psoas retraction time was around 10 minutes and a couple of seconds. So I do believe that all the thigh symptoms, the transient thigh pain, the transient weakness of the thigh, and the devastated motor lesions, they can be avoided with the right technique and a short psoas time retraction.
So it seems speed, efficiency, and experience, right? So if you look at that, how many cases do you think one needs to get to this point where you're so comfortable doing what you do, Cristiano?
Yeah, I don't have a magic number, but I do believe that we have to follow the acquisition of competencies, as I mentioned, you know, to go to the OR to check other lateral surgeons operating on, you know, to participate of cadaver labs and to have some proctoring during your first cases. I don't have a magic number, but I do believe that you have to start with more simple cases, 3, 4, but 4, 5 is definitely the level to be approached. I mean, if you check in your office, you have the major part of your patients, you need to do 4, 5 and 5, 1. That's the reason I'm adopting the single position surgery for my single and 2-level, 3-level cases. Through down to L3 to S1, we're doing lateral A lifts and X lifts in the same position and with perk screws. And we do believe that this increased relatively our efficiency in our OR, and we guarantee, or we try to avoid the flat back, the iatrogenic flat back in post-op patients, even in ordinary single and 2-level cases.
All great points. I think there are a couple of questions from the chat room here, and one of them was, do you go from the concave or convex side? Do you have a preference for which side you do, or how do you choose that?
Yeah, as you guys know, the transpsoas you can approach by the left or the right side. There's no problem about that. I mean, but I prefer every time I can to assess from the concavity. But which will drive my approach is the 4-5 level. So the position of 4-5, if we have a scoli case that opens away from the crest, is probably the side that we will approach. That conventionally is the concave side.
Go on the side of the open 4-5. That's basically your choice.
Yes. Yeah.
One more question to take from Dr. Chapman again. The patient had a previous far lateral procedure and needs another surgery at a higher or lower level. Will you go ipsilateral or contralateral? So in the previous procedure already lateral.
Yeah, great question. I mean, if I don't have any issues about anatomic concerns, I will change the side. I will go to a virgin side, non-operated side. But I had some cases that I had to revise or to add levels in the construct, so that I revised it for the same side, and I didn't have any problem. I mean, if you're cautious to create the retroperitoneal corridor, and to pay attention about that and keep away all the retroperitoneal structures, I don't think that a previous transpsoas approach is a contraindication to get back the same side.
All right, thanks, Cristiano. That's amazing. I think, again, for want of time, we're going to move on to the world famous Seattle Science Lab. Dr. Rosikian standing by with Dr. Jimenez. And let's do a cadaver demonstration. Rod?
So I'm just going to quickly, Neil, I'm going to give a quick talk and then I'll jump in the lab. I'm just going to basically, in the lab, we're going to do an ACR, but I'm just going to quickly go over some, what I think are some important tricks about doing lateral surgery. So I think Christian talked about this, but you know, it's minimally invasive. there's a steep learning curve. The 3D anatomy you really have to understand. And over the last decade, we've really understood how important the lumbar plexus can be. So when I first started practice here in Seattle, it's Swedish, we really had a hard time getting an access surgeon. So doing these approaches by myself and spending time in the lab and doing cases like this where, you know, you have to go anterior, and it was a nightmare to try to get an access surgeon to come in and help expose. And so when I first started, you know, these were the exposures. You can see here how big. So Dr. Anand, this is Dr. Anand's exposure. You can see he's got a really big exposure. He's got 4 different surgeons in the room. And then, you know, the patients in the hospital for days, if not weeks. And then you can see my exposure, it's very small. It's minimally invasive. The patient goes home the next day. And you can get a lot of work done. You know, the principles are the same. You want to get a fusion. So, you know, when I started doing this in thoracolumbar pathology, so if you've got a burst fracture, you can go in from the back, stabilize it, then do corpectomy. And you can see here, you can get pretty posterior and get a nice cage and get good anterior column support and restoration of the thoracolumbar junction. And as I started doing it, I could see that I could go pretty far posterior, and I could get big, large fragments going out from the front. And here's another case that I did, and you can see how the retractor position is key. So you got to place the retractor so you can angle it posteriorly, and just like you would any other corpectomy, you want to go all the way back. And then I started looking at doing this, for example, for a large calcified thoracic disc. This is a patient who'd had, I think, 4 different attempts to have this thoracic disc removed. You can see on here, the disc is so large that it's pushing into the spinal canal, and I'll point, this is actually the disc material in calcified portions here. The cord is completely draped over it. And so instead of trying to take this out from a posterior approach, why not go anterior, create a nice cavity. You can see I went all the way across the disc space. I did not attempt to take out this large calcified disc that was attached to the dura. And you can see here that piece is floating in the canal. And we decompressed it. And as I felt more comfortable in the last 12 years, then I started going down the lumbar spine, using it for complex tumors such as this metastatic case. Patient had radiation, burst fracture, stenosis, and here's the contrasted scans. Again, you can go in and do a really nice resection and get nice anterior column stabilization. And then we started doing this, we started use it more for revisions. Here's a cage that we were able to pull out anteriorly and revise it. And again, doing this over the last 12 years, we understood how important the lumbar plexus is. And just in the last year, we published our book on the surgical anatomy of the lumbar plexus. So I'm going to put a plug in for this book. But really, as a neurosurgeon and orthopedic surgeons, we don't know that much because it's a new approach. And we studied the lumbar plexus and the psoas and all these fantastic approaches that have come about in the last 10 years. So I'm going to jump into the lab, and then if anyone has any questions, we can ask at the end. Thanks.
Thanks, Rob. You're live, Rod. You can see you.
You can see, so what we're doing today, so I have Dr. Lincoln Jimenez, who is from the Mayfield Clinic, and we're going to do a lateral ACR at the L4-5 level, and the retractor, this is like cooking, so we already did some of the stuff behind the scenes for you guys, and Lincoln is going to point to the anterior part of the retractor and then the posterior. So
this is the anterior part of the retractor right here. This is the posterior portion of the retractor here, anterior and posterior. This will be the L4 and this will be the L5 right here.
and then we have some nice C-arm images, and actually this is a fairly large normal disc space. And at L4-5, it can be a little treacherous. So the main thing, whenever the retractor placement is key when you're doing an anterior column resection. So I like to, especially at L4-5, start at the 50-yard line. And you can see on the lateral image that we have, we've got the retractor placed right at the 50-yard line. And then again, as Christian mentioned, the retractor time is essential. And so we've already placed the retractor, and then we've done the discectomy. So that's what you guys can see in your field of view. And then the important thing about doing an ACR is really doing a very thorough discectomy. And so you can see here, this is the end plate of L5. This is, and then and then the top portion, and then this is the end plate of L5. And then this is L4 at the very top here. So you can see we got a nice cavity that we're working in, and then the remaining structure, and this is the way I've kind of done ACRs, is the very last structure you want to take is an anterior longitudinal ligament. And we do a very thorough discectomy. So we use these instruments, and today we're using the Globus Mars retractor. And I like to use these box cutters that they have, and you can take a lot of disc material out. And so what we're going to do is we're going to put the first box cutter in. We've taken some of the disc already, but we're going to take some more. And so Dr. Jimenez is going to go ahead and place that in there, and we're going to take the disc material. Let's get a shot there. Let's go a little bit more. And then I like to go all the way across the disc space and go across to the other side. So great, and then one more shot. So you can see we went all the way across, and then I can kind of feel this. It's kind of loose, and then I can kind of turn it. So I know that just to kind of guess the size of the implant. So this came out. We got some disc material in there. And then let's go ahead and clean out some more of the disc. And then this Mars retractor actually has so there's like a second retractor that's on here. And this is going right underneath the anterior longitudinal ligament. And as I was saying earlier, this is actually the very last structure that I go after. So most people, when they're doing this procedure, they initially start very anterior and then they go posterior. But really, what you want to do is you want to get a very nice discectomy, clean everything out. And the last thing I do is take out the anterior longitudinal ligament, which is underneath this penfield right in there. And once you take the AOL, which is going to be right there, can you guys see that?
Can you put the camera a bit just to see the anterior part?
Yeah, it's kind of I think probably that's going to be the best view, but this is, yeah, there we go. There we go. So you can see, can you guys see that? So let me get my hand out of the way. It's right there. See the, whoops. So it's right there. See it?
Yeah, we can see it.
Okay. So now what we're going to do is we're going to carefully resect that. So we have let's see the long anterior. So I'm going to take this super retractor off, and I'll just show you the attachment. So we're going to take the super retractor off, and then this gives you a little bit more flexibility, and we're going to try to put this just underneath the ALL. And then let's get a shot there. So you can see that. You guys see that on the fluoro?
Yep.
And again, I sort of, when I first started doing this, in fact, a lot of us, accidentally, we were so far anterior that, the whole ACR procedure was sort of accidental, because when we started doing this, we realized every time I would do one of these things, sometimes you would rupture the ALL, and before you knew it, you could get like 14 millimeter cages in without any problem at all. And so here I am, and again, I don't like to use a sharp instrument. I just manually take out the ALL. And some people use a knife, and others, like myself, just kind of slowly. I like taking some of the disc, and then I just use a pituitary and slowly work my way down. I've also used a cob to kind of slowly get the end plate off, and then you can see I'm just going, and I can see where the blade, you guys can see where that retractor is anteriorly. So I know I'm safe. I'm in the disc space, and I'm carefully taking out as much disc material as possible. And I'm going all the way across. And then now we have, we're gonna figure out, so here's the second part of the procedure, which is to use this nice expandable dilator. And you can see here, when I dilate it, you can get the disc space to open up. So we're gonna put that in the disc space. So Lincoln, go ahead and put that in there. And then, so now the ALL is gone. So I'm gonna pull out the other retractor. And then we're gonna kind of put it in there. And again, this is to do two things. One, it kind of gives you a sense of, let's get a shot there, of how much of the ALL we've resected, just based on feel. Go ahead, Lincoln. So I think it's pretty much, the ALL is pretty much gone. And this happens to be a very normal disc space in this cadaver. So I think our cage is gonna be, so you can see that. Do you guys see that there?
Yep.
You know, nicely that opened up. So we can tell just by putting this in, and then let's show you guys with the ALL kind of gone. Do you guys see that?
Yep.
So I'm gonna put the retractor down so you can see the ALL is gone. There's maybe a little piece there. So Lincoln, go ahead and get the pituitary and just get that last piece. And of course, you know, the main worry is always, you know, vascular complications from taking the ALL. But I think if you do a very thorough discectomy and you're very methodical about staying within the disc space, knock on wood, I've never had a vascular complication, but just the fear of doing it, you know, makes me want to really do a thorough discectomy. Now we're going to put in, so this is an expandable cage that we're going to put in, and you can see it's also got the ability to put anterior instrumentation, because once that ALL is gone, it's extremely unstable, and this cage will actually move quite a bit. And you can see just by putting it in, see how easy it is to put this thing in? Well, it's because the ALL's gone. So we just drop that in. Let's go ahead and get a shot there, Tyler. Okay, so now let's go ahead and expand it. And retractor time is very important here. So we're at 4:05, and the plexus, you know, I don't like to be in here for more than 20 minutes at a time. So if I go over 20 minutes, I'll bring the retractor down and irrigate it a little bit. So let's go ahead and get a shot there. And you guys, can you see that? So we could probably use a little bit of a bigger cage. This is actually the largest cage that they make. But the foot plate, the end plate, we probably could, is this a 45? It's a 60, wow. So it's pretty large. So let's get a shot there. And then now it's kind of torqued out, and then we're gonna get a, so I like to leave this on because it's painful to try to take it off. And then we'll look, and typically when you're doing ACR, the main problem is that the cage typically tends to float more anterior. So here, when you take the ALL out, it creates this kind of dead space, and the cage always migrates more anterior than what you anticipate. So we're going to try, and this patient has probably one of the biggest disc spaces on the planet. So now let's go ahead and get another Tyler, keep coming up a little bit more. There you go. Let's shoot that. So you guys see that there? So that's almost perfect position for the implant. And then what we're going to do is let's put a screw in. So we have one screw we're going to put in. And then we're going to go ahead and loosen the, so Dr. Jimenez is going to take out the, and then, so there's so you can use, there's a awl, but the bone is so soft, I think we could just probably do it without the awl. So I like to put in a couple screws just to hold it in place. So let's get a shot there. And then, so we'll go ahead and, so shot again. So there's our, let's go ahead and get our screw. And then we'll put one on the bottom and one in the top. So go ahead, Lincoln, go ahead and put that in there. And then once we, do we have another screw? Okay, great. So we're gonna put both screws in, and then I'll take the retractor out so you guys can see the psoas and the ALL. One more shot. Great, and then let's go ahead and take it out. Shot there. Okay, perfect. Okay, let's get the, put one more screw in.
Another deal.
Shot there. Tyler. Okay, so I think we're good just with that one, and then let's go ahead and let's get one more.
So Ross, that looks really, really good. And actually, I like that technique a lot. I got to compliment you on that. It's a very elegant technique where I see you just thin the ALL as much as you can and actually let it give on its own rather than cut it. It looks to me that's what you're doing, right? So when did you move away from the knife? Because I know a lot of other surgeons still use a knife to cut it. What made you move away from the cutting knife?
I think it just makes me tense. I don't really like using a sharp instrument to try to take out the ALL. And like I said, I mean, when I first started doing this, this was back, you know, a lot of the ACRs, we sort of, you know, it was on accident that we ruptured. So I just found, and especially I'll show you the, I call it the ALL rupture instrument. You know, this the expander, it kind of, it just let's get one more shot there. It just made it totally unnecessary for see this here, Neil. I really like this instrument because it basically, you can, and it's blunt, and you can just put it out there and stretch out the anterior fiber.
Expanding it and letting the ALL rupture. No, I love that. It's a very elegant technique, and I'm all about it. I think that is really.
And I just think it's safer. And you can see, I mean, you can see how much we expanded the disc space open there. And
So
I'll just show you.
Questions for you on ACR, as we've got to keep moving on. That was a great demonstration.
Here, look, there's the ALL's completely gone. And I didn't even have to use a knife. So look, there it is right there. See it?
So to complete the subject, do you always put 2 screws or 1 screw? And do you always do an osteotomy or no osteotomy in the back?
I like to do an osteotomy in the back because you can still get it to crunch down more. And
if you do an osteotomy, do you have 2 screws or 1 screw?
From the front?
Yeah, in the front. Would you put both screws in, up and down, and then do the osteotomy? Only have 1 screw. So
normally, if I'm going to do it all in one day, I will actually just put 1 screw in. If I'm going to stage it, like do the next day or something, then I'll put 2 screws in. And then some of my colleagues here at Swedish have tried to up my game and now are doing intradiscal osteotomies from the back. So namely Jens Chapman. So, I mean, what's cool is that, you know, this field is evolving, and to be able to go anterior and get 30 degrees of correction is I think, a game changer, and working within the disc space. And so your blood loss, I mean, you can see here, we're just working in disc space. So there's, you know, there's not really that much blood loss when you're doing a lateral ACR, and you can get a pretty significant amount of correction.
So question on that, do you use a 30-degree cage or the 20-degree cage?
This one is 30.
Is that your go-to cage usually on an ACR?
Say that again?
Would that be your go-to or normal cage?
You know, honestly, it's patient dependent. This one, the disc space was very normal. But I would say, I'd say on average, it's probably in between. And, you know, because the nice thing about these cages are, and I'll just show you, you know, this is one where it's collapsed, and then here's one fully expanded. So you can see the difference, and then sometimes it's in between, you know, so that's the nice thing about these expandables is it really, and I like to go to where it's kind of finger tight, you know, because it's very easy to fracture the end plate as well. So
No,
great,
so
thanks everyone. I don't want to go over my time.
A couple of quick questions from the chat room. Do you go bicortical with all the screws? Bicortical or unicortical with your screws?
For the lateral instrumentation, you know, it would, I think bicortical is what we want to try to do, yeah.
Okay. The other question was, you put a screw in L5. Are you concerned with the iliolumbar vein?
No, because we're pretty far lateral. We're not as anterior.
The other thing, you're coming from front to back, so you probably will miss that. You'll miss the iliolumbar vein. I agree with that. In terms of that. Talking quickly of corpectomies, I know we never got there. Can you comment on how you control or identify the segmentals, and what do you do with that? Do you clip it? Do you identify it? If you were to do a corpectomy?
Yeah, so the first thing I do when I do a lateral thoracic or lumbar corpectomy is identify the segmental vessel before doing anything. So that's the very first thing I do. I go in and place my retraction and then look for the segmental. And actually I will bipolar it or clip it, because if you don't do it early, you know, and it gets stuck, and I've had this happen where you're like, oh, this is great. I didn't find a segmental anywhere. And then meanwhile, it's under your retractor, and then it's got vasospasm because you've been retracting on it the entire case. And then at the end of the case, you go, well, geez, what's all that bright red blood? And it ends up being that you've avulsed the segmental that was behind your retractor. So I don't screw around with the segmental anymore, and I go and find it, especially if you're kind of upper thoracic spine. Those segmentals can be very large coming off the aorta, and they can be extremely difficult to stop the bleeding when you know, you've got sort of an angry surgical field, and you're sort of trying to close up and put a chest tube in and do the rest of the surgery.
There's one more quick question. That's the last one. So I think the question is more like, if you inadvertently tore the ALL, you do not have a retaining implant, what tricks do you have to place an interbody implant? Because it keeps slipping anteriorly, right? The ALL is gone. So it's a pretty good question in terms of what do you do now to keep this implant inside? You do not have a self-retaining implant.
So I've actually had that happen, and I think, you know, I think you gotta have to do what's safe, and I've bailed on, you know, an ACR where I couldn't get the cage to stay, and you go in from the back and just do a T-lift, and you can actually get very good correction and results. So I've had that happen. Yeah, I think it's not worth it to try to put an implant in if you don't think it's gonna hold.
I think Joe Kim answered that question, and I do exactly the same thing. You can flip the lordotic implant backwards. So you put the lordosis posteriorly. It has worked pretty effectively for me, and yes, I've done it many times. So I said the same thing, and I think that's one trick you could use where you can flip it backwards and place it, and you can jam it in because posteriorly it remains tight. Anyway, for want of time, I think we got to keep going. That's a fantastic demonstration, Rod. Really love it. Very elegant, very nicely done. Thank you, guys. And Dr. Damon there. Let's go on to Ron Lehman and talk about the anti-psoas, pre-psoas approach. Ron?
Great, thanks, Neil. Can you hear me okay? So we're going to talk a little bit about the anti-psoas approach, but really sort of reasons not to perform the approach, or certainly relative contraindications. We've seen now through most of the talks, there's many different ways to access the spine. And one of the things that we know about with the anti-psoas approach is it takes a relatively natural plane between the psoas muscle and the vessels.
Dr. Lehman, you have control of the slides.
It's not forwarding. It's getting stuck. And so we can see the natural plane here, and really for every single level, there's about 18 millimeters of a natural plane. In addition, we can reflect the psoas muscle, which gives us a little bit more excursion. And for all the advantages, though, we also want to take into consideration that the L5S1 is really just an A-lift in the lateral position. Despite this, there are many complications. Certainly with anterior surgery, we know that the vascular injuries can be at roughly 4.5%. And this is pretty consistent with the anti-psoas approach as well. And so in this study, in terms of complications, and this lumped in the 2.5 as well as the L5S1, the postoperative ileus and vascular injury rate was about 3%, so consistent with an A-lift. Subsidence actually in this particular study was a little bit higher than actually with the trans-psoas approach. We all know that this is not a very good A-lift or anti-psoas patient. And so I think this is one of the things to take into consideration of when not to consider an anterior type surgery. And we also hear the adage sometimes, well, if you put the patient in a lateral position, they get much thinner, but this doesn't hold, and this logic definitely does not apply. But there are some vascular considerations for these approaches. And I think this really goes with the trans-psoas as well. As Troll and Cristiano pointed out, there's some things we want to consider. And so we can take a relatively straightforward adult idiopathic deformity case like this, and this is probably a misstep 2, maybe 3 because it's 30 degrees, but relatively straightforward case. And when we think about doing the anti-psoas approach or even an A-lift at the L5S1 level, one of the things we want to do is look at the left common iliac vein. And you can see there at L5S1, there's no fat stripe under the vein. And that means it's going to be very difficult to mobilize that. And so with an A-lift, it's a little bit more forgiving, but one of the things to consider when we talk about which approach to use for these cases. And so preoperatively, we want to plan this. And we want to think about it on the axial T2 weighted image. What we're looking for is a plump wide vein that's going to be easy to mobilize. You can see the really generous corridor there. In addition, as long as there's fat under the vein, we know that we can mobilize the left common iliac vein. The image there on the right-hand side of the screen shows that it's thin and there's no fat. That's going to be a very difficult case, especially in the first few dozen of these that you do. And also cases where the vein is going to be in the midline. And when this occurs, you can actually go lateral to it, but one case that you may want to consider doing a posterior approach instead of the standard one. And as Cristiano mentioned also, anytime it's a revision case, prior anterior surgery at that level, these can be catastrophic type approaches. So one of the things we want to consider, and really that's more lends itself to an all posterior approach. And so you can see here in this schematic how you were able to get lateral to the vessels. So one thing to consider, but certainly an advanced technique after you've done many of these. In addition, if you have a very large middle sacral vein, you have to be aware of this ahead of time. You can see this one is quite generous, so these are going to have to be ligated. We typically recommend using ties as well as clips before you approach the L5S1 through the interbody space. And in other cases where we can see the sympathetic chain, and this is a 2-5 approach, but you can see the sympathetic chain is here quite nicely. And if you see it, you want to make sure that you mobilize that, get it out of the way so you don't end up with a sympathectomy. The one benefit is that even if you do end up injuring the sympathetic chain, most of the time this function does return, because even when they did sympathectomies in the past, resecting a centimeter, oftentimes that does recur. And then when you take a normal size MRI, this is one of the great things that you should also do is just read the report, because there could be something like a pelvic kidney, which could really obviate your anterior based approach. Just one more thing to consider when we talk about this. This has been brought up, but this is one of the difficulties I've had in the first really 10 cases with very, very large osteophytes. And when the large osteophytes are there, and I'll highlight this in the case, the vein can get very stuck to this, very difficult to mobilize, and it really lends itself to getting tears of the vein, once again, versus an ALIF or anisos approach. And then rare conditions like situs inversus, where the vessels are on their side. Certainly if you're doing a transpsoas approach, you can do that from either side, but typically the anisos approach is done with the left side up. So this would be a case where I would go all posterior, or if you're using a transpsoas approach, you could approach it from the right at L3-4. And transitional anatomy is another thing to consider. Certainly when the bifurcation is high or low, always take this into consideration before you do this. And once again, we'll highlight this with a case where this can be an issue. So when we talk about all these things and relative risks and contraindications in vascular injuries, I like to highlight with some of these cases that I've experienced. So this is a case of failed back syndrome, had a prior decompression with significant sagittal imbalance. Gentleman is 78 years old, multiple prior posterior surgeries, laminectomy, doesn't even fit on the EOS screen, has bilateral foot drop. You can see his generous laminectomy here posteriorly. So this is a case that I thought the anisoas approach would be beneficial for me. However, he had transitional anatomy, and I appreciate this ahead of time, but I didn't appreciate how much of an issue it potentially could be. In addition, look at the massive osteophytes. And so not just on the left-hand side, but also on the right-hand side of the patient. And so even though we approached it with the anisoas approach and looking at the vein, we can see a very similar thing where it's basically attached to the osteophytes, it's tented, and there's no fat stripe there. And so after trying to mobilize the left common leg vein, it wasn't successful. We basically aborted the case, flipped the patient prone, and then did a T10 in the ilium with a fusion mass TLIF posteriorly and helped to improve his sagittal alignment. Second case is adult idiopathic scoliosis, and at the age of 11 in another country had a mudsliding incident with a fracture dislocation at L4-5 that went untreated. You can see here the significant coronal and sagittal alignment as well as a significant takeoff comparatively. And so initially I thought this would be a nice approach to go anteriorly, especially because of the fracture dislocation posteriorly, to address the L4-5 and L5S1 levels. But as you can see here on both the CT scan and the MRI, there's a large callus formation which really adjudicates L4 to S1, which is more pronounced here in a 3D reconstruction. So really no mobility there, very challenging case. Plus we also know with fractures like this, with callus formation, the vessels can also be stuck. So my situation, that was not an anisoas approach or an ALIF approach. This was an all posterior, ended performing a vertebral column resection of the L4 segment. So very uncommon to do a VCR in the lower lumbar spine, but you can see here overall good coronal and sagittal alignment as well. The next case is an adult idiopathic curve. And this is one that I think I really want to sort of focus on more for a lot of the surgeons. And one thing that's been proposed, there's 3 classifications. We talk about coronal malalignment, and the sort of the type C curve, which is the one where in terms of the thoracolumbar curve, that the patient is listing to that side. And so oftentimes what we see is a lot of surgeons will want to try to place multiple inner bodies. And so they'll place 3, 4, 5 inner bodies from S1 all the way up to L1 in these types of cases to help correct the coronal curve. But as we do all the things we normally do to help address the fractional convexity, to help ultimately horizontalize the LIV of L4, if we place 5 or 6 inner bodies, we can see what ends up happening is that we can really push this patient further over to the left-hand side. And when this patient becomes significantly malaligned in the coronal plane, much more than they were before pre-op, they're very unhappy. So in this type of case, it's very beneficial to do your posterior column osteotomies to aggressively mobilize the spine from a posterior approach. And so I recommend in these types of cases, address the fractional curve, just do 4-5-5-1 if you're going to do an anti-psoas or ALIF or lateral type approach, and do your correction from the posterior aspect to once again achieve good coronal correction. Because if you push this patient more over to the left-hand side, which is a common error, that patient is going to be very unhappy. And then the last case, in terms of when to consider not doing an anterior approach or an anti-psoas approach, is a case of a previously Harrington rod. This is a physician, also had a history of neuroblastoma as a child with radiation therapy, presented with bilateral foot drop. And you can see here, once again, significant sagittal plane malalignment. In addition, take a note of the arrow, which shows a significant osteophyte. Moreover, the CT scan really shows that she's already pretty lordotic at the 4-5 and 5-1 segments. And this particular slice in the sagittal CT scan doesn't show how significant these osteophytes were. They were almost wrapped around the vein. That's how prominent they were. And so despite seeing multiple access surgeons, they all said this is not a great approach. And so in this particular case, we performed an asymmetric extended pedicle subtraction osteotomy. So once again, safer from posterior approach, and overall got her very well aligned. So I think, like was previously said by Chol, it's very difficult to have one approach nowadays. There's many different tools we have, but also it's important to understand the goals of the surgery, what the patient's anatomy and the disease process is, because certainly by having many different things in our armamentarium, we're much better able to treat safely the patient and overall still achieve what our correction mechanics are going to be. So there are some benefits of doing these approaches, I think has really been pointed out, including the anti-psoas approach for all these benefits, but also be aware when not to perform the approach and when to think about alternatives to it. Thank you.
Thanks, Ron. That was fantastic. And for want of time, I'm going to take the one question again from Jens Chapman. How do you manage the ureter? What do you do with the ureter? Do you see it every time? Are you aware of it? What do you do?
Yeah, it's actually a great question for a couple of reasons, which I won't mention on here, but it is becoming more and more significant, even in the medical legal realm. So one of the things that we do is that, typically ureter, when you retroperitoneal, you don't always see it, but we typically try to find it now. So we look for it before we start doing anything, whether it's on the approach or even when we're taking our retractors out to ensure that we did not injure the ureter. Because the downside of injuring the ureter, it's only unilateral. And so oftentimes, even if they do have symptoms, you may not notice them even until they leave the hospital. And they'll present 8 to 12 days later with some potentially significant issues. Obviously, ureter doesn't bleed. You don't see the leakage of the urine because it just looks like seroma fluid. And obviously, you have 2 kidneys and 2 ureters. So oftentimes, even if they do have some issues initially with urination in the hospital, most typically those recover and the other kidney sort of takes over a little bit. So it's one of the big mysteries of when they occur in order to diagnose them, even the postoperative period. So we do really try to find them, and our vascular access surgeon does always annotate in his operative note that the ureter was visualized and was not injured.
And if I may expand on that, Jens, I think absolutely true. Today, we really make sure it sweeps with the peritoneum. You keep sweeping everything off the psoas till you actually see just the psoas muscle and the pre-psoas space. And the ureter goes with the peritoneal fold. So before we do anything, you make sure there's nothing in that path there. And actually, I'm more comfortable making sure the ureter is not there pre-psoas than I was trans-psoas. But I really can be sure it's not there, to be honest, when I see it. But anyway, we can go back. But that's a great question. We published on the injuries way back in 2009 and how to handle them. And I'd like to go on to finish my talk. What I thought I'd do is, as you all know, we've been doing circumferential minimally invasive correction for pretty severe deformities for many years now. And I thought, how do we do lateral and how do we use lateral as an adjunct to this procedure? And I think it's pretty important what to avoid and how do we go across. Alexis, I can't advance it. Could you advance it for me?
You should have control, Dr. Anand.
Moving. Well, there we go. So I think I had to disclose a slide, but what's really important if you're going to do circumferential minimally invasive surgery, this is basic but extremely important because they behave very differently with the strategies we use. You have to be sure what you're dealing with. Is it degenerative? Is it iatrogenic with massive scarring in the back with laminectomies, or is it an idiopathic scoliosis? And I'll tell you why in a minute. You also need to obviously be aware of the coronal imbalances and thoracic kyphosis. These all play into the decision-making, again, for circumferential, minimally invasive correction without an osteotomy. We go past indications and selections, assuming you made the right indication for this patient to have surgery. And now comes the planning of what are you going to do. And for us, that's become really important. We have a staged strategic protocol for dealing with these patients, where the first stage is predominantly laterals, all the way from 5-1, working your way up. We choose today to do an oblique pre-psoas approach, and we can talk a little bit about it, but I have no problem. What do you do? But laterals along the way. And then we stage them, take a standing x-ray, look at indirect decompression, reassess alignment, and then fine-tune posteriorly. And all this falls in place. And we've never done a single osteotomy since 2006. Any, not even a facetal section. But how does that come about? Let's talk about what lateral does, right, in this setting. It regains height of the disc space. You want to create lordosis. You want indirect decompression. But the key is that is your main area of segmental fusion. That's the reason you're doing the interbodies beyond actually achieving correction. It's a really important point, but we're not fusing in the back. The fusion is interbody. So it's important we get that fusion. And so the other issue is, can you actually do it MIS? And everyone talks about rigid, stiff curves and flexible curves. What really matters is it fused or not? Because obviously if it's fused, then what matters is a bridging osteophyte, which you possibly could break, or is it a complete global fusion, which you cannot break in the lateral approach? It gets very hard to break. So to us, that's all that matters. Is it fused or not? Nothing else, because flexibility curves have never let us assess it. They don't bend. There's no way of knowing is that fusion. I will show you some examples. Next is osteoporosis. How's the bone quality? Because again, it matters. Osteoporotic is not going to be able to achieve what we just talked about earlier. And then we talked about normal indications for a lateral approach. So the other thing is, at least I believe, if you're going to do it, it should be entirely MIS. Circumferentially MIS. Then you get the advantage of what we're talking about. Whereas if you do laterals and then do open posterior osteotomies and open surgery, you're really not maximizing that advantage of MIS surgery, and it's an unfair comparison. You also want to do all your lordosis at 4-5 and 5-1. You really want to maximize that, and for that you need to know your corridors and obviously know how to do it. So the other key element to us is using ligamento-taxis to achieve that physiological harmonious reconstruction and lordosis of the spine. Remember, there's not a single osteotomy here. You're recreating a physiological lordosis. So everything matters what you do. And how do you get to that? So first is x-rays, long standing today, we have EOS, look at your parameters, align them, measurements, we know that. The MRI has become extremely critical for us now to analyze this in terms of stenosis, UIV, and the anatomy, and little was talked about, Ron talked about it, and we'll dwell into some depth there. CT scan is also becoming very important for us to analyze what we can do and what we cannot. How do you plan that? And then absolutely bone density. If the T-score is less than -3, I'll try not to do it, but at least start them on Forteo or some parathyroid hormone analog, Timlosa, whatever you want. So I know they're on it before I get going. If it's really bad, I will not do it. It's between 2 and 3, we operate with Forteo or Timlosa on board. And that's worked very well for the last 12 years. So we talked about laterals, transpsoas, or pre-psoas. Today we prefer to go pre-psoas. I find that a little more comfortable and easier. But the key, I think, for anyone doing laterals, you should know the thoracoabdominal approach. That's what it really is. You need to know the anatomy, know what that is. We've done so much surgeries through that. It's helped me immensely understand it. But ultimately, what we're doing, like, really is breaking up that thoracoabdominal approach into 3 small incisions. The bottom one is 5-1. Today we do 5-1 through a lateral approach, 3-4-4-5 to the middle one, and 1-2-2-3 to the other. So if you would extend all that, it would be one big thoracoabdominal approach. But the muscles are spared. That's the key. I've had this argument. We're not stripping the muscles all the way. You're just dilating through the muscles, through these, but it becomes important. As I said, we do A-lifts today through a lateral approach. It is an A-lift. Ron alluded to it. to an oblique lateral. I prefer that today when I'm doing multi-level corrections to do that. And so let's talk about MRIs. Here's a 3-4, good access pre-psoas between the psoas and the aorta. But let's go to 4-5 now. And it stopped on me, Alexis. Can you move it? If you go to 4-5 now, you're going to see all of a sudden, this vessel is already bifurcated on me. I'm not able to move this forward, Alexis. It's already the key you're looking for to me now when I look at these MRIs. Can we go backwards? Maybe 3-4 slides back. To me now, today, when I look at the MRI, let's go back some more, please. It's going forward. Yeah, backward, backward. One more. One more. One more. There you go. You can stop at that. So if you look at 4-5, it already is split on me. The key element I'm looking for today, because we do our A-lifts in the lateral position, all I'm looking at is, am I going between the bifurcation or am I going left of the common iliac? It really has changed the entire procedure. If it's bifurcated, like in this case, I can go left of the aorta or common iliac, if you will. If you go now to the next one at 4-5, I'm not sure why it won't move. If you go to the next one, it's already bifurcated, and there's no way I could get left of the aorta safely or common iliac safely, and the inferior and vena cava was already bifurcated. I'd much rather go between the bifurcation through a oblique lateral A-lift. Similarly at 5-1. The other thing we've seen repeatedly is if it's bifurcated, low down, or I'm sorry, high up, it is a segmental anomaly already. The bifurcation tells you there's a segmentation problem right away. It actually correlates really well. Just look at where the bifurcation is, and that determines how you're going to approach it between your vessel or lateral to the vessel. So I'll just keep going. If someone can advance that for me to 3-4 slides up, there you go. You can see that. And you can't go lateral to that. And similarly, you go between the bifurcation on that one. Can we go one more slide, please? One more slide. And in contrast, if you go here on this one, even 5-1, I can approach lateral to the common iliac. There is a clean pre-psoas space. That's a segmentation anomaly, but allows me to access 5-1. And in this setting, the iliac crest does not come in the way. It basically is behaving as a 4-5. And that's something you'll see with vascular anatomy. So to us, this has completely changed my indication how I approach that and what I need to do. We go to the next slide, please. And that's just quickly running through it to see how we go now. You'll see again, 3-4 is fine. I got pre-psoas access. But at 4-5, there's the psoas flying up. You can see the bifurcation already. I cannot go lateral. I'm going between the bifurcation at 4-5 and at 5-1. So this patient is basically getting a A-lift at 4-5 and 5-1. If we can advance it again, please. There you go. So that's what he would get. So that determines what I do, lateral or bifurcation. If we can go to the next slide, please. So let's go to some case examples of how we deal with this further. Let's take this patient, severely symptomatic, scoliosis, quad weakness for 6 months. And if you look at the MRI now, look at that massive sequestrated disc herniation at L2-3. I can't get that through a lateral approach. Maybe Rod can doing a corpectomy, but that is not a lateral for me. The same patient with the deformity, we did a unilateral T-lift, got that fragment out. I was hoping he'd get better, but he remained really symptomatic 6 weeks later. And then we went in and did the deformity at that point and corrected his deformity. But that is better to approach the T-lift now than trying to get this guy through a lateral and that piece. So watch for the sequestrated disc fragment. Today, that's our only contraindication for indirect decompression for the laterals, unless the facet is fused. As long as the facet's open, it will open up. Well, I used to look at grade 4 facets and this and that. They all seem to open up if you work the disc. It's really a sequestrated fragment you got to watch out for, but that's hard to get. A central disc bulge you can get. So take this patient now. Again, idiopathic scoli, PILL mismatch of 32. And here's the MRI. Nowhere do I know is any area fusing the spine or not. If I just went willy-nilly now and did laterals, And you go now to the CT scan and look at that. Can you advance it, please? For some reason, I've lost control. Okay, it's coming. There you go. I got bridging osteophytes at 3 levels now. But it's truly a bridging osteophyte. Look at 3, 4. I could probably cut through that. It's only at 1 point. 3, 4 is a little more tricky, or 2, 3, sorry. Can I break through that or not? But I could give it a shot. Don't do it now, but it's worth a try. It's not a global fusion. And I'm not asking anyone to try it, but the facet is open. So these are the things you're looking for. Can I open this space up? And can I do it safely? This tells me, okay, as a bridging osteophyte, maybe I can cut through that. And that's exactly what we did. And if I can run through that, you can see there's an osteotome coming in the next one. And that's an osteotome that breaks it, take it across, let it go across the next level, and work that disc space to get that height and build it up. So you just got to be meticulous with it and release, release, release. Break each level, including that level that was so-called fused, and break it. So if it's an osteophytic fusion, you could break through it. As opposed to, so this patient, as we did the lateral, look at the correction. It's completely corrected after the lateral, and there's no reason for a single posterior osteotomy. All we have to do is contour the rod, lay it in, get a little more correction, and correct the deformity. And that's how circumferential MIS works, by working the system. So we didn't have to do a single osteotomy, not a facet resection in this case, by releasing that disc in the front. You take another patient, massive deformity, PILL 51 degrees. And if you go down again, same thing, but now we look at the MRI, again, we don't know if it's fused or not. Go to the CT scan. It is completely fused at L3-4. No bending film would have told me that. It's really hard to find that out. So when you're planning now, I have to work above and below to get my correction. More than likely, 3-4 I'm not getting, well, that's rock solid fused, including the facet. It's fused. The facet solidly fused. That's not coming through a lateral. So my only chance is up or down. Working the discs that are there, which have gas in them, which will allow me to break through. So you work that disc and build up on it and get as much correction as you can, leaving that fused segment alone to get that correction you need, including a 5-1 oblique lateral ALIF, if you will, to get all the lordosis you need. So again, you can see the stage 1 after the lateral. It tells us how much correction we got, and now we can fine-tune dial posteriorly on the second stage and get that correction you need, again, without a single osteotomy. So that's how circumferential MIS works for us. It's a very strict protocol. Bone density is extremely important. But imagine if it was osteoporotic, that's what you're going to get. You're not going to get the correction. It subsides completely. These are all my patients, by the way. ACR, subsidence, vertical split fracture within 6 weeks of putting that screw in. This was in 2009. I thought there was a date somewhere. But this was all mine in 8 and 9, and I learned a lot of these things. Bilateral pedicle fracture. This happened in 2009. This patient, please do not do a lateral approach. It basically is disc ankylosing spondylitis. You go in the osteopenic, you try to lift that disc up, the bone gives rather than the disc. When you get a bilateral pedicle fracture, and it taught me a lot, and I can't tell you how many pants I wet that day, but this was really a tough one. So don't go there. What do you want is this, lordosis, with your thing placed just behind the ALL. That's how you get your lordosis. It's important to place that just behind, as opposed to placing it posteriorly. If you place it posteriorly, again locked up, you truly lose your lordosis. You can see in the other slide. Here's another case, posteriorly placed implant in a patient who's stenotic from before. Look what happened. Push disc material into the canal. This patient lands up with severe stenosis. When you go to the next slide, please. With a foot drop post-operatively, and needed a laminectomy to relieve that. If you get a foot drop, it didn't come from a lateral. A foot drop is stenosis. An L4-5 does not give you a foot drop unless there's stenosis. Lateral approach will give you a quad weakness or an L4 weakness, not into a 5. So if you get that, watch it, get an MRI, look at it. I can't advance the slide again. There you go, severely stenotic. Then we went in there, did a laminectomy, and got it relieved. And that it made a complete recovery actually. But watch it. Don't put it in the back. Can you advance a slide, please? Watch your placement of your graft. The opposite side really matters. You start getting opposite side pain, don't assume you distracted it. You probably went into the foramen with your cage and you cannot see it with an X-ray. Get a CT scan. You'll miss it on an X-ray. It's hard to look at that. Have a low threshold for a CT scan if you got an opposite leg weakness when you've gone in and done this. And so again, watch that. You don't want that. In general, this is what you want. Try to get 20, 25 degrees of lordosis at 5.1 and about 15 to 20 degrees of 4.5. If you got a high PI, you're going to work every other disc also, 3.4, 2.3. A low PI, you can get away with just 5.1 and 4.5, getting good lordosis. But that's what we're trying to achieve in every patient. And going back to what's degenerative, hydrogenic, and idiopathic, if it's degenerative, it tends to correct. Next slide, please. There you go, it completely corrects. It's a discal problem, release the disc, put your antibody, great correction, put your screws in. Nothing needs to be done. You don't need many more fine tuning. If it's idiopathic, it does not derotate. I've yet to see a single idiopathic spine ever in 15 years that derotated after a lateral. So be careful. You get that, you just put screws in, that's not going to correct. You have to derotate it out to get it and translate and correct it with your posterior maneuvers. So that's important if you're planning circumferential minimally invasive or others rush into an osteotomy, but if you could derotate it, you will get the correction you need. Next slide, please. And so that's the lateral on that patient. Next slide, please. And you have severe coronal deformity with thoracic kyphosis. You got someone like this, again, same protocol. Do your laterals as you need to do as we talked about it. Get your release the same way. Next slide, please. Get your release the same way. You can see again, post stage 1, nothing correct. The curve is exactly where it was in the coronal plane. You need screws and rods to derotate that. And because he's got thoracic kyphosis, you got to go up. That's the only time we go to T2 now. Thoracic kyphosis post first stage. If it's still there, then you go to T2. And that's the next change in our protocol. Next slide, please. And last but not the least, lateral is not the be all end all of life. This patient, prior ALIF, infected with a bowel puff they didn't know, develops a small bowel obstruction, exploratory lap, abdominal sepsis, colostomy, reversal, complete nightmare. I'm not going anywhere in front of that belly. But that's how she is, a severe flat back, extremely active, actually an Oscar-winning director. Next, please. 3-level TLIF with an SPO is an excellent option to get your correction. So there are many, many tricks we have. You don't have to do a lateral on every patient. There are really good techniques we have to correct these things. She did unbelievably well. So I want to end with the fact the lateral is not be all and end all of everything. But if we are going to use it, we can use it very effectively in many ways. Next slide, please. I think we're done. That's our post-op. And thank you. So with that, I'll end and we'll take questions. I know we're running a little bit over time, but we'll take some questions. If the panel has some questions, please go ahead. And there are some on the chat box. Okay, I'll look at the chat box. There are a couple down in the chat box. There were questions there that actually Dr. Young Hai had a question, but I'm trying to get back to that on, it's from China all the way. And he had a question on essentially, how do you decide on an ACR? I hope Rod is here. The size of the cage and how far do you keep distracting? That's a great question because so loose, you could put any size of the cage you want. So his question is, how do you decide what size cage you put in and what's the limit of your distraction? Is Rod still here? Rod?
Dr. O is not in the room.
Okay, sorry. So maybe I can answer that. It's a great question, Young, and I think that's why it's really important to predetermine what you want. I actually have stopped going to a 30-degree cage and I stay with the 20 because another question was raised about point loading. I'm pretty concerned with the 30-degree cage about the point loading that occurs. So I use, at least if I'm doing an ACR, which is actually pretty rare. We do not do ACRs routinely unless it's an adjacent segment kyphosis. And if I do, I'll do a 20-degree cage. I don't know if the rest of the panel members had any other thoughts on that. Joe, Ron, any comments on that? If you do an ACR, Cristiano? Go ahead. You're muted.
Yes, yeah. Just to point it out what you mentioned, we do need a very good ALL release. Otherwise, you're gonna be in trouble having subsidence. So this new generation of expandable cages, maybe you can act in a more efficient way, not having a fish mouth, because the 30-degree cage, the problem is that it tends to be anterior when you implant the device. So one thing that Rod mentioned is that you have to completely clear all the disc space from behind, from the most posterior part of the disc space until the LLL, and to guarantee that you release the ELL completely, because otherwise you're going to be you cannot force to implant your device. Otherwise you're going to have subsidence.
Well, that's good point, Cristiano. There were a couple of other questions about facet cysts. If you had a facet cyst, would lateral be good? And I agree, facet cysts are challenging. I think Dr. Lehman already answered that, in that I personally, if the patient's significantly symptomatic from a radiculopathy, from a facet cyst, I'm decompressing that directly to make sure that is gone. I wouldn't rely on my indirect decompression to do the job. It all depends on symptoms. Now, we did not have a lot of symptoms, and I still saw it there. I might stage it and see how we did after my first stage. But if he's symptomatic, no question. Anyone had any other thoughts on that? You're all nodding. I agree. We all would decompress it.
Yeah, only because I've never really had, I don't have enough experience not decompressing it, but I've heard from several colleagues that do a lot of indirect decompression, even in the setting of facet cyst is relatively small. Indirect decompression works. It kind of tensions it, and then by stabilizing the facet joint, hopefully it'll resorb. But it's probably safest to do a direct resection, knowing how adherent the facet cyst tends to be with the dural tube.
Right. Couple of questions, I guess, addressed to me. Do I go from the concave or convex side? And young guy again, what's the criteria for the side? So I can tell you what I do, always the left side, irrespective of concave or convex. I got to tell you why. When we move to the pre-psoas approach, I'd rather be on the aortic side or the common iliac artery side than ever on the inferior vena cava side. I'm on the right side. So very rarely, I've only done one from the right side, and someone who had left-sided 3-level laterals already done. And that I went from the right after really studying the anatomy. But yes, 99.9% left side. So the curve doesn't matter, concave or convex. I don't know if anyone had any other thoughts on that. And there is some good data. There's a really good Korean paper actually, as well as a paper from HSS, looking at the left side corridors much better than on the right side in terms of safety. But I know people do it from both sides. I'm not here to say right or wrong, just giving you my personal opinion. Ron, you have any thoughts on that? Mid side?
Yeah, I completely agree. I always go from the left side as well. Obviously with the pre-psoas approach, you can, get all the way down to L5S1. So in my hands, especially if I'm starting at 5-1, I do that 5-1 incision and do the approach at 5-1. And then I use that same incision to do 4-5. And so I end up coming oblique, which allows me to protect the vessels. And essentially you can always get 4-5 from there as well. You can make a counter incision, but it's nice that your vessels are protected. You can still release the ALL with an ACR type equivalent and get your cage in and sort of bend it around the horn and come in obliquely, and then work my way up from there. So the only time that I think the consideration would be to go to right, like I said, if you case like situs inversus or something like that, which is pretty rare. But if I saw that, I would go posterior.
Cristiano, you do transpsoas, so I think it doesn't apply as much to you. I'm going to assume you go right or left, depending.
Yes, I go right or left. Even if I have to include 5-1, when I do my lateral A-lifts as well, and for any reason I have to do transpsoas and upper levels, I use the right side to approach 5-1 as well.
Joel, any thoughts on that? This is a very common question.
I go both ways, but I tend to go mostly on the left side, but I'm much more like looking at what's going to give me trouble at 4-5 and choose that 4-5. If all is equal, I like going on the concave side because I can, instead of going like 4-5, 3-4-2-3 in sequence, if you start at the top and work your way down, you're not going to have this weird, fanning pattern of approaches on the convex side. You can just kind of reach everything through a more kind of narrow approach corridor when you go on the concave side. So I try to go on the concave side as much as possible, which tends to be on the left side most of the time, but it's usually dictated by 4-5.
We'll take, I guess, one more question, and that's from Sol himself. His question was, what are your thoughts on stopping at T12 L1? And I'm putting that to all the panel. T12 L1 in the setting of MIS. Ron, you want to go up, take it? Stopping at T12 L1.
Yeah, I generally always go into the lower thoracic spine. And so my sort of blue plate special is T10. However, T9 is actually probably a better level to stop in general, just because there's no motion then between T8, T9. There's always a little bit of motion. Paper published out of China about 2.5 years ago that showed there were still 8 degrees of motion between T9 and T10. The downside of going to T9 though is that you get into the facet joint above when you go to place your pedicle screw with the standard start point, and then you also have to worry about the reconciliation of the thoracic kyphosis. So you always want to stop caudal to the thoracic kyphosis, the apex of the thoracic kyphosis. So if you can do that at T10 or T9, that's great. If for some reason the thoracic kyphosis apex is a little bit more caudal, then you could, do T11. The downside obviously with T11 and T12 is the pedicles are quite large. So, I still use 7.5 screws in that area, but there's sometimes that the pedicle is even bigger than 7.5 screws. So that's typically why I go to really make sure you cross the junction. So for me, it's sort of L1, L2 or T10. I don't typically stop in between that, but there are some caveats.
Cristiano, any thoughts on that? Anything to add?
Yes, I totally agree with what Lynn had about. In my preference, I tend to try to reestablish the lower doses and just stop on L2. But when I can't do that, my tendency is to go to T10.
Well, I'll just give you
I asked that question.
All right, so you go. What do you do?
I asked that question because I have so many cases where I stopped at L1, like an L1 to S1 or an L1 to L5. And I was really hoping you guys would say, oh, I stop at L1 all the time. Or, stop at L1, which is stopping at T12 L1. So now I'm really nervous. But I haven't had a problem, and I've done a lot in the last 10, 15 years. So I'm hoping that they're not going to have a junctional problem. I think if you do it open, it's a big problem because you tear down the posterior osteotendinous complex that provides dynamic stability. But I've been stopping at L1 a lot in the past and keeping my fingers crossed that it's not a problem. It hasn't been, but it would be nice if I think that one of you guys said you'd done that too.
It's truly something worth looking at, and we did that a bit too. I can tell you, I'll probably go to T12, but for me, it's really not that. For me, it's the first parallel normal disc on X-ray and MRI. For example, if 11-12 disc is absolutely normal on MRI, and it's off the carbon parallel, and there's not the beginning of kyphosis, I'm very comfortable stopping at 12. But,
no, stopping at 1.
Yeah, but 1 I rarely would. Even if 12-1 disc is normal, I
right.
did prove that even if 12-1 disc is normal, I'd rather go into 12 for what Ron just said. The pedicle at 12 is really good. I like the 12 pedicle. It's a good pedicle as opposed to L1. The L1 and L2 pedicles aren't great. So that's one of the only reasons why, even if the 12-1 disc is great, I'd yet go to 12. And so I got a better pedicle screw there. And similarly, if the 12 screw is not good, I'll go to 11. But I have no problem stopping at 12, 11, or 10 based on the disc above. And we just got a paper coming out on that. And I think you guys from St. Louis, Ron, showed that. It didn't make much of a difference whether you stopped at 12, 11, or 10.
Yeah, it doesn't typically make much difference.
Yeah. All right. Any other pressing questions? I don't know. There's a quick question. Approach surgeon for pre-psoas. Quick word, yes or no? Do you use approach surgeon for your 5-1 pre-psoas?
Yes. Yes.
Yes, me too. For 5-1 only, not the others. All right, with that, I think we better end out here. We can go on talking forever. Thank you, first of all, to the faculty. Amazing. Thank you, SSF. You guys are the most amazing platform for any meeting of this kind. And thank you all the attendees. We still have 127 participants still up there. Thank you guys. Wish you all a good day and stay safe. Thank you.